I'd like to welcome everyone to today's webinar on the 2019 CAQH Index findings. Before we get started, I want to take a moment to go over just a few administrative details. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a question and answer session. In your GoToMeeting control panel, you'll see a questions box. Please type your questions or comments into the field and hit enter. Please note that this webinar is being recorded, and the link to the recording of this webinar, along with the slide deck, will be posted following the live webinar and will be emailed to all registrants following this live event. You can actually go ahead and download the PDF version of the slides in the handout section of your GoToMeeting control panel. Our speakers for today are April Todd, who is the Senior Vice President of Core and Explorations for CAQH. She is responsible for leading the CAQH Core multi-stakeholder collaboration that is driving the creation and adoption of healthcare operating rules for electronic administrative transactions and establishing a common foundation for the operational components of value-based payment. She also directs the research functions for the organization, including the CAQH Index. Christine Bernaska is the Director of Research and Measurement at CAQH, where she oversees the CAQH Index along with internal and external research efforts to help demonstrate the impact of streamlined business practices in healthcare. Prior to joining CAQH, Christine led the Price Transparency Initiative at a nonprofit healthcare company in DC, focusing on the development of state web-based price transparency tool. Without any further ado, I'd like to go ahead and hand it over to today's speakers. April, it's all yours.
Thanks, Sam. Thank you all for joining us today, and thank you to Weedy for sponsoring this webinar to help share the information from the 2019 CAQH Index. On the webinar today, we're going to be providing you with a brief overview of what the index is and how we conduct the index every year, as well as review some of the high-level findings, and then Christine will walk through some of the detailed findings for the different transactions that we measure through the CAQH Index. So for a brief overview of the index, we'll talk a bit about how we do this survey and who is engaged in the survey. So this is the 2019 CAQH Index. This is the 7th annual report that CAQH has done. And what this report does is it is a culmination of surveys that are done of plans and providers to track industry progress in the transition from moving from manual to electronic administrative processes. The index measures adoption of fully electronic administrative transactions, specifically those that are mandated under HIPAA, as well as additional transactions that are emerging within the industry to address administrative needs. In particular, the index tracks the cost and time associated with conducting those transactions and the mode with which they are done, whether it's electronic, manual, or through some partially electronic means, such as through web portals. The work that we do through the index is guided by an Index Advisory Council. This is a council that consists of numerous stakeholders throughout the industry, including plans, provider organizations, as well as various different experts within the field. This year, of particular interest, there are a few new things that the index has been able to track. What you'll see new this year in the index are estimates of partially electronic portal use and the cost and time associated with that. And we also, for the first time this year, able to report, in addition to the savings potential that exists from moving to electronic transactions, we're also able to report the total spending and the cost that the industry has avoided annually by moving to electronic transactions. So the transactions that are tracked by the index really start at the beginning of the administrative workflow through the end. And so that workflow includes the transactions that occur before a patient visit is scheduled through when a provider is paid for that visit. So this includes eligibility and benefit verification. This is typically done before a patient is seen and throughout, both before, during, and after a patient encounter. Includes prior authorization and provider referrals. Also includes, once a patient is seen, the submission of a claim and any attachments and coordination of benefit submission that occurs related to that encounter. Includes transactions where providers are checking on the status of their claim submission, and also includes transactions related to the payment and detailed remittance advice that goes along with that payment that is provided to the health plan for that service and encounter provided to the patient. So next, I want to go through a few definitions in the index just to be clear in terms of what it is that we are measuring and tracking and what we are not. So the first definition that is of importance is what we are tracking when we are tracking the cost, administrative cost in the index. The cost and the savings estimate tracked in the index account for the labor time to conduct the transaction. The costs do not include any systems, IT-related costs, or any pre- or follow-up work that is done to prepare or respond to a transaction. And in terms of the transactions themselves, we break how they are conducted into three different modes. The first mode is electronic. These are automated transactions that are conducted typically using the adopted HIPAA standard if there is a HIPAA adopted standard. Second is a manual transaction. This is a transaction that requires end-to-end human interaction. This includes things such as telephone, fax, and emailing information. And the third is mode of transmission is a partially electronic transaction. This includes transmitting information through web portals and interactive voice response systems. Some additional metrics to review from the index are related to different ways that we measure some financial items. The first one that has historically been tracked by the index over time is potential savings. When we talk about potential savings, this is the savings that the industry could achieve by switching from manual and partially electronic transactions to fully electronic transactions. And then there are also three new metrics this year. First one is estimated spend. Estimated spend, this is the amount of spend that occurs for medical and dental plans and providers on conducting a specific transaction by mode. So this pulls together the volume and cost for all of the transactions conducted electronically, partially electronically, and manually. There's also a metric for electronic spend. This is the amount that the industry spends just on the conduct of electronic transactions. And lastly, we have a metric this year on cost avoided. Cost avoided is the amount that has already been saved by the industry by conducting transactions electronically versus manually or partially electronically. Moving on, this slide shows the different transactions that the 2019 index is tracking. Over time, these transactions have been fairly consistent. We have increased the number of transactions that we are able to track over time. And this year, in particular, there's one item I'd like to flag that is a difference. This year, we are able to report on attachments. Attachments have been difficult to track within the industry, and we have modified the definition of that this year to allow for reporting. Attachments refer to those that are done for prior authorizations, claims, and appeals. We also started asking this year about a new transaction related to value-based payment. This is any clinical information that would be exchanged related to a value-based contract. We have started to collect information related to that. We did not have enough information this year to be able to report it, but we will continue to ask about the exchange of medical documentation for value-based care into the future. The data collection effort this year has been very similar to previous years. The time frame for data collection is typically from June through the middle of September. And the reason for this time frame is to collect information from the health plans after claims have been fully adjudicated, which is typically a 3 to 6 month time frame. This year, similar to prior years, the results for the index represent about 50% of covered lives in the US. This year, we had a provider response that more than doubled from prior years, and want to specifically thank our Index Advisory Council members for really stepping up and helping to increase the response rate from providers this year. And so with that, we'll next go over some high-level findings. So in terms of high-level findings, there are 5 high-level findings that we'll highlight and then hand it over to Christine to walk through the transaction findings in detail. So first, this year we continue to see electronic adoption of the transactions improving. Most transactions have continued to improve over time. There are still a couple of transactions that lag in the industry, and Christine will go over those in a bit more depth. In particular, what was encouraging this year is that adoption for transactions in the dental industry improved for every transaction for the dental industry. Second, we continue to see industry transaction volume increasing. For some transactions, it is increasing more quickly than others. In particular, we are continuing to see an increase in the volume for eligibility and benefit transactions. Third, the industry cost savings opportunity increased slightly this year, and primarily for the dental industry. And the amount of cost that could be saved by moving to electronic transactions represents 1/3 of the current spending on administrative transactions. Fourth, this year we have quantified the savings potential associated with moving from portals to fully electronic transactions. In particular, you'll see some new findings related to prior authorization associated with moving from portals to the electronic standard. And lastly, for the first time this year, we are reporting information on the costs avoided and are able to see really that the industry has made significant progress over time, has saved over $100 billion annually by moving from manual to electronic processes within the industry. So with that, I'll hand it over to Christine to walk through some of the detailed findings from the index.
Great. Thanks, April. And thank you to everyone attending the webinar today. I'm now going to share some high-level findings with you related to adoption, volume, and savings opportunities. Looking at medical plan adoption, you'll see that electronic adoption remained relatively stable or increased for the 8 transactions reported. The biggest increase occurred for claim payments, followed by coordination of benefits. Moving to the dental industry, for the first time since 2015, adoption increased for all 5 of the dental transactions. Eligibility and benefit verification and remittance advice adoption increased the most at 5 percentage points each. Looking at slide 15, slide 15 highlights the relationship between volume and potential savings opportunities for the medical and dental industries. Medical volume increased 17% from last year, while dental volume increased 3%. The potential savings opportunity also increased for both industries. Looking at the overall industry savings opportunity, you see that the savings opportunity also increased 7% this year from $12.4 billion to $13.3 billion. The increase was mainly driven by an increase in the dental savings opportunity. We're now going to focus on the average cost per transaction. So looking at the table on slide 7, you will see that the biggest savings opportunity for the medical industry is for prior authorization, followed by claims status inquiry and eligibility and benefit verification. For each of these transactions, manual costs are high for providers and plans. Looking across all the transactions, each manual transaction on average costs $5 more to conduct than an electronic transaction. If all 8 of the transactions were conducted electronically, the medical industry could save as much as $42 per patient encounter, with the majority of savings being for providers. Savings also exist by moving from partially electronic portals to fully electronic transactions. The largest savings opportunity is for prior authorization. $2.11 can be saved on each prior authorization by conducting the transaction using the mandated standard as opposed to a portal. Switching to the dental industry, the biggest savings opportunity is for claim status inquiry, followed by eligibility and benefit verification. Similar to the medical industry, manual cost to conduct these transactions is high for plans and providers. Looking across all 5 transactions, on average, each manual transaction costs about $6 more to complete than an electronic transaction. If all of the transactions were conducted electronically, the dental industry could save $30 per patient encounter. The savings is 3 times greater for providers than plans. Savings opportunities also exist by switching from partially electronic portals to fully electronic portals, with the biggest savings being for eligibility and benefit verification. This year, as April indicated, we are able to not only report on potential savings opportunities, but also on the overall spend associated with conducting administrative transactions and the costs avoided through automation. Looking at the medical and dental industries, you will see that they have spent about $41 billion conducting administrative transactions measured in the index. Of that, $13.3 billion, or 33% of the spend, can be saved by switching from manual and partially electronic transactions to fully electronic transactions. The progress the industry has made to automate the administrative transactions has saved the industry over $102 billion annually. Focusing on the individual transactions, the medical industry has spent about $34 billion conducting these 8 transactions. The highest spend is associated with conducting eligibility and benefit verifications, followed by remittance advice and claims status inquiry. These 3 transactions represent 80% of total annual spend. Despite the high spend associated with conducting eligibility and benefit verifications, the medical industry has avoided over $68 billion annually by automating this transaction. By automating claims submission, the industry has avoided almost $11 billion in total annual costs. Switching over to the dental industry spends almost $7 billion conducted the listed 5 transactions. Spending is highest for eligibility and benefit verification, followed by claim payment and remittance advice. These transactions account for almost 75% of the total annual spend. Through automation, the dental industry has avoided almost $3 billion in annual costs associated with conducting eligibility and verification checks. In addition to estimating the cost savings opportunities, we are also able to estimate time savings opportunities associated with switching from manual to electronic transactions. On average, providers spend 7 minutes more conducting a manual transaction as opposed to an electronic transaction. For patients requiring all 7 transactions, a provider could save 50 minutes by conducting the transactions electronically instead of manually. The transactions with the highest time savings opportunity is prior authorization. On average, a manual prior authorization required 21 minutes to conduct, while an electronic transaction required 4 minutes to conduct. This year, we were also able to estimate the time a provider can save by switching from partially electronic to fully electronic transactions. A medical provider could save on average 9 minutes by conducting transactions electronically as opposed to via a portal. Focusing on the dental industry, we found that on average, it took providers 8 more minutes to conduct a transaction manually compared to electronically. For a patient requiring all 5 dental transactions, a dental provider could save on average 38 minutes by switching from manual to electronic transactions. The transaction with the highest time savings opportunity is for claim status inquiry, followed by eligibility and benefit verification and remittance advice. Dental providers reported that they spend 17 minutes on average conducting a claim status inquiry manually compared to 4 minutes electronically. Looking at time saved by switching from portal to electronic transactions, we found that on average, providers could save 3 minutes by conducting transactions electronically as opposed to via a portal. I'm now going to dig deeper into some of these findings, starting with eligibility and benefit transaction. For each transaction, I will share trends in adoption and volume, and where possible, provide context around the findings. And I know that we've been sharing a lot of information with you, but as Sam has indicated, we'll have time for Q&A at the end, so please feel free to jot down your questions or you can start sending them at this time. On slide 26, we see that adoption of eligibility and benefit verification dropped slightly for medical plans and rose 5 percentage points for dental plans. For both industries, manual use dropped. The volume of eligibility and benefit verifications increased for the medical and dental industries and remains the transaction with the highest volume for both industries. Plans and providers reported that the increase in volume is due in part to the increase in plan complexity, which may result in more manual transactions. Dental plan and providers have indicated that manual intervention is often needed when dealing with the unique dental needs and requirements and thus difficult to get away from. Moving on to prior authorization, we see that adoption remains low despite the fact that a standard is in place. Barriers such as lack of vendor support, state laws mandating manual interventions, and inconsistent use of data content have been cited for the lack of adoption. This year, we saw an increase in portal use, which aligns with efforts by plans to encourage providers to submit prior authorization requests through specific plan portals. The volume for prior authorization remains one of the lowest among the transactions studied. And despite plans requiring fewer prior authorizations this past year for services, providers still find this transaction a challenge, as cited by many studies, including one from MGMA. In the future, we expect to see the volume of prior authorization requests increase, as medical plans indicated that new innovation in certain service categories will result in the need for more prior authorizations. Focusing on claim submission adoption, we see that this transaction continues to have the highest adoption rate for medical and dental plans and has remained relatively stable for the last 3 years. Despite the stable adoption rate, volume has increased for both medical and dental industries. This increase in volume, not surprisingly, closely mirrors the increase in volumes for claim payments. Claim submission volume, however, is higher than claim payment volume, given payments are often made in bulk where one payment is associated with multiple claims. This year, we were able to report on attachments, which includes prior authorization and claims and appeals attachments. In the 2017 report, attachments only included claims attachment. It's important to remember this as you look across the years, given the measures are slightly different. Adoption for attachments is the second lowest among the transactions. The lack of an attachment standard has deterred vendors, plans, and providers from investing in solutions to help automate the transaction, resulting in high manual burden. Looking at the volume of attachments exchanged on slide 36, it is worth noting that the volume remains among the lowest and accounts for less than 1% of total transaction volume. Moving on to coordination of benefits, we have seen a steady increase in adoption. This transaction has the second highest adoption rate after claim submission. Partially electronic use has dropped to an almost non-existent level. The growing use of electronic COBs may be a result of the industry working together to share plan enrollment data electronically to help with the coordination of patient benefits across plans. On slide 40, we see the adoption of fully electronic claim status inquiries drop slightly for medical plans and increase for dental plans. For both industries, manual use has dropped. Looking at the volume of claim status inquiries, we see a drop in overall medical volume driven by a decrease in electronic and partially electronic volume. The decrease in medical volume may be due to the fact that providers are only checking on the status of a claim every 30 days. This may be a result of quicker adjudications and payments from plans. The increase in manual volume for both industries may be due to the lack of acknowledgments, resulting in providers calling to find out the status of a claim. This results in high manual costs and time to conduct, which we saw earlier in the presentation. For medical plans, claim payments saw the largest increase in adoption. This corresponds to the increase in EFTs reported by NACHA. Dental adoption remains low, though, due in part to the lack of trust in electronic exchange mechanisms. Dental providers have indicated that they'd rather carry a check than deal with EFTs. Looking at the volume associated with claim payments, we see that the medical industry experienced an increase in volume driven by the increase in electronic volume. Electronic and manual volume increased slightly for the dental industry. The increase in overall volume closely matches that of claims submission, as we discussed earlier. And finally, we will discuss remittance advice. On slide 46, we see that adoption increased for both the medical and dental industries. While dental adoption is up, we still see high manual use. We have heard from dental providers that the lack of information on a remittance advice results in dental providers printing out EOBs and manually reconciling the payments. For both industries, remittance advice volume continues to increase. The medical and dental industry saw an increase in both electronic and partially electronic transaction and a decrease in manual transaction. The increase in electronic and portal transactions is due to duplicative posting, which allows providers various opportunities to access the information. This concludes my discussion of the detailed findings. Again, if you have any questions, please feel free to write them down and we'll be happy to answer them. So with that, I'm going to turn over the presentation to April to discuss actions for the industry to consider as they help maintain and improve upon the achievements we just discussed.
Thank you, Christine. So in the index, based on the data collection this year and examining the trends from prior years, there are a few different calls to action that we see for the industry moving forward. The first one is really to focus on efforts to reduce provider burden. For most of the transactions tracked by the index and the savings opportunities that we see for the transactions to move to electronic processing, most of those savings opportunities exist for providers. And in particular, this includes transactions related to eligibility and benefit, claim status, remittance advice, and prior authorization. Second call to action is to accelerate standards and operating rule development to support the harmonization of administrative and clinical data exchange. So one of the things that we've seen in the index over time is that the industry has made significant progress in moving administrative transactions from a more manual process to an electronic process. However, as the industry changes over time and the need for intersection between administrative and clinical data increases, there is a need to adapt and evolve our administrative transactions to be able to accommodate this. And this is something that we need to start addressing, or we may stagnate in terms of where we are in the industry today. And we see that with transactions such as prior authorization, where there is that key intersection between administrative and clinical data. The third call to action is related to the need for vendor adoption of all standards and operating rules. Really, vendors play a key role in the industry in helping providers in particular and plans be able to exchange information electronically. And in some parts of the industry, particularly related to prior authorization and for dental providers, there is a lack of solutions that can help with those transactions in terms of being able to make them more efficient and transmit information electronically. And so there is a need to place some focus in particular on those few areas. And then lastly, there is a need for expanded research related to the administrative workflow. This year, as we've reported, there are some new things we were able to report this year based on some modifications in some of our survey questions, as well as an increased sample from providers. We will be looking to continue to increase that sample next year, as well as continue to add new topics related to value-based payment, as well as pharmacy transactions. So with that concludes our presentation portion of the webinar. I would draw your attention to the index report, the full index report that is available on the CAQH website. You can go to this link and download the full report. And then I would encourage individuals, if they have questions, to please submit those to us. We're happy to answer them on the remainder of this call. And maybe just to start off, Christine, just a question about the data itself. And does the data include all health plan administrative costs, including pharmacy?
No, currently pharmacy cost is not included. We are working with NCPDP currently to create a pharmacy index survey, but for the time being, we just are reporting for medical and dental.
Okay. So another question is around attachments. Question is there a standard yet for attachments? Is that the reason for the increase in adoption?
So currently there's not an attachment standard. I know CAQH Core is currently working on one, but no, there currently isn't one in place. So yes, I do think that in terms of the data and adoption and why it remains relatively low is because there is not a standard, currently not a standard in place.
Yeah, and related to that question as well, there isn't necessarily an increase in the adoption this year. We did have a change in how we asked the question compared to 2017 when we were able to track that. In 2017, we were just asking about claim attachments, and this year it includes claim and prior authorization and appeal attachments as well. So not exactly an apples to apples comparison over time there. And really the reason for that is it was a challenge for us to collect information, get information submitted in the 2018 index related to attachments. So we took some feedback back from the industry and how we could collect that and combined all of the transactions that get attachments together. And that made that reporting easier for our health plans in particular. Another question, why have remittance advice transactions and E&B transactions grown so much compared to the others?
There's a couple of reasons that we've heard, and I'll answer, and then April, if you have anything you want to add. For remittance advice, we've heard from providers and plans there's some duplicate posting that occurs so that providers can access the information in multiple places. So the duplicative postings has definitely been a cause of the increase. Also, the increase in the complexity of plans we've heard has been something that's been impacting volume. There seems to be a lot more requirements. For eligibility and benefit, there's a lot more going back and forth in terms of checking, a lot of manual calls that are being made. Eligibility and benefit, we've heard, is checked multiple times throughout the process as opposed to just once. I don't know if you have anything else you want to add.
Just with eligibility and benefit transactions, this is an area I think where we've heard that we're seeing an increasing volume just because of the complexity of the insurance plans. And particularly, I think now that we have multiple different plans that span from fee-for-service to value-based payment, bundled payments, a whole host of things in between, there's just a desire to collect information more along that path. And this is an example of one of our call to action areas where the industry has made some great progress related to eligibility and benefit transactions. It's one of the transactions that has the most electronic adoption. But this is also an area that improvements can likely be made in what information can be transmitted, and creating some operating rules, for example, around how to communicate some additional information through that transaction that could help with some of those areas of interest related to value-based payment, for example.
Yes.
So another question, this is kind of similar to the previous one. Does the index survey pharmacies or pharmacists?
We currently don't. As I mentioned, we're excited about a partnership that we have now currently with NCPDP, and we have just started talking with PBMs to collect some information on their adoption as well as the cost component, similar to what we currently collect for the medical and dental index reporting.
Okay. And then another question is related to remittance advice. This is similar to one of the other ones as well. Why has electronic adoption dropped for remittance advice? I think maybe take that one. As we've seen the duplicative nature of remittance advice go up, and you have the plan sending remittance advice through the standard transaction as well as through the web portal, we are seeing that volume increase, but also as more goes through the web portal, just by basic math, you're getting a lower percentage that are electronic and a higher percentage that's going through the web portals.
Yes.
So let's see if we have any other questions coming in here. I'm not seeing any more coming in here.
Oh, is there? I think I see someone asked about the 2020 index data collection effort, so I can give a little bit of information about that. The 2019 report was published in January, and believe it or not, we are already starting to think about the 2020 index. Our goal is to begin data collection in May or June, similar to this time frame, and again end in August or September. So if you have interest in participating or learning more about that, definitely feel free to reach out to us. You can reach out to us at explorations@caqh.org. And as I had mentioned, we're now also looking at PBMs as well as medical and dental for plans and providers.
All right, I think that's the last question we're seeing come through. So, Sam, we can hand it back over to you to close out the call.
Thank you so much, Christine and April. That was a fantastic presentation. And just as a reminder to all of our participants that I will be emailing you the link to the recorded webinar in case you came in late, but also the PDF version of the handout. So thank you again to everybody for joining us today, and I hope you have a great week.